thalamic tract to the frontal lobe to figure. If I stump my toe, I immediately want to go like this, right? I want to move. I step on a nail, I immediately want to move that, right? That comes from the spinal, it comes up the spinal cord and comes up through the thalamus, and the thalamus says, what body part do I need to assess? What body part is concerning me right now? The thalamus says, it's the leg, it's the foot, and so the thalamus sorts it out, and then I have a motor response going down from the cortex down to the spinal cord through that corticospinal tract.
You said spinothalamic junction?
Yeah, the tract.
Tract.
Just a tract. Yep. So anything that messes up along that way in the spinothalamic tract affects the sensory and the ability to interpret sensory. Okay? So again, the thalamus is the train station that sort of sorts everything out. It's like the hub, it's like the airport hub, if you will, and sorts it out. True discrimination is also housed back here. It's the position of where you are in space. I'm able to stand here. I can stand on one leg. I can hop on one leg. I can do, I can turn around in a circle and I'm not going to fall over because I know where I am in space because I don't have a disruption in the spinal lobe. I'm in the frontal lobe, excuse me. Size, shape, and texture. I know whether something is rough, whether something is smooth, right? And the intensity and locality, I know whether something is deep pressure or light pressure, right? So all of that sensory stuff is right back here, okay? Okay, what is this? Okay, a review. But you will see that the MCA territory gets that parietal lobe too on the side of that parietal lobe on both sides. Okay, so patients who have MCA strokes can have motor and sensory because that parietal lobe is also, the vascular supply is also supplied by the MCA and the medial, the ACA. Okay, let's talk about this. Let's review. 4 is the prefrontal cortex. That's your motor strip. Right behind it, behind this big crevice right here, is your sensory strip. Right there. Now, if I put motor and sensory together, this is a better picture of the homunculus. You can Google it or whatever. This is a better picture of the homunculus, where the foot in the sensory strip, same thing. It still sits behind here, but your foot is bigger right here, right? You need a lot of sensory input from your feet when you're walking, so you don't walk on stuff you shouldn't be walking on. You don't need a whole lot of sensory input from the hip or the knee. You don't need a whole lot there. You don't need a whole lot from the trunk, but boy, you need a whole lot of sensory input from the hand, right? I need to know I'm pushing this button. The only way that I know that I'm pushing the button is 2 ways. I see the green thing right there, and I know how hard I'm pushing it, right? I need all that sensory input. Think about how many times we use our thumbs, right? So you need all that. And then you have the face and the tongue, of course, okay? All right. So all of these have to do with your tactile sensation, pinprick, vibration, your temperature, your position sense, and again, your touch that we just talked about. But all of that is housed right in here. So motor strip, sensory strip, right here. Okay. Your association areas are right back here. So if I step on a tack, I may not know it's a tack, but I know it's something sharp. And I know it's something sharp because it's something I've recognized, because I've stepped on something sharp before. Right? If I step on a Lego, when my kids were little, we had those little Legos. Oh my gosh, in the middle of the night, to step on a Lego in the middle of the night when it's dark, when you're walking across the room. And I know what it is because I not only sense it, but I have some experience with it, and that's where these association areas come from. So the double simultaneous testing is this. Where do you feel me touching you, right or left? And then they'll tell you. Where do you feel me touching you, right or left? Where do you feel me touching you, right or left? And what they're going to do is they're going to exclude the left side because they have right side. So double simultaneous testing is when you do both and they can only feel one side. Graphesthesia, when you write numbers, right? You write an 8 in their hand, they know that that's an 8. Can you put something in their hand and they know what it is? You put a paper clip in their hand, hey, that's a paper clip, right? So it's things that you can sense, that you have experience with, that uses these association areas back here, behind the sensory strip. I think it's pretty neat that he came up with this in 1909. I don't know about you, but I'm pretty impressed with this person. Okay, let's look at environment areas 39 and 40. So 39 and 40 are like right here, okay? And they are in the MCA territory, again regarding that Wernicke's, that receptive language. Do you understand what I'm saying to you? Okay? So there's significant networking here in auditory, visual, intellect with the frontal in terms of I understand what you're saying to me, now what is my response to that? So there's a lot of, and even in the limbic system, do I need to be concerned? Do I need to protect myself? Is there any sort of feeling I need to have about that? So there's a ton of networking in this language center. So 39 is the reading center, and that's where you get your math functions, that kind of stuff. This is the area that causes dyslexia. So if you have patients that are dyslexic, this is the area that cause that, or dyscalculia. My husband can't add worth anything. He cannot. He's not had a stroke, but it's difficult for him. He just doesn't make the connection. Area 40, again, confuses right and left, okay? And that can also be inherited. And then you have Gerstmann syndrome, which is really rare, but it's an acquired neurologic insult that causes dysfunction in that. And you'll have some of these things as well as apraxia. So they know that a toothbrush is a toothbrush, but they don't know how to use it. They try to write with it, right? So they know that what objects are, they just don't know how to use them. If I handed them a phone, they wouldn't know. They might try to, brush their teeth with it or something, okay? So dysfunction there, so that 39 and 40 are the Wernicke's area for receptive language. Do you understand what I am saying to you? Okay, again, looking back here on the sensory and the parietal, arm and face sensory loss, contralateral MCA, because we're dealing with sensory now, not just motor, okay? So it looks like the same chart, but it's not the same chart, okay? Pure leg sensory loss is really rare, but it has to do with the contralateral ACA. And again, coextensive arm face sensory loss, and you can have that with motor loss, with these contralateral distal ICAs or proximal M1s. The loss of language reception, it can be fluent aphasia, where you can't get anything out and you don't understand anything. Okay, these are people where doing the NIH is really difficult for these people. You can't get them to cooperate because they can't understand you. Again, spatial neglect, again, usually it's MCA, and it is usually on the right side, okay? Global aphasia, we see that too, usually on the left MCA, and then Gerstmann's right here, okay? So that's the sensory piece, okay? Now again, this temporal lobe localization is down here. Primarily it's auditory and olfactory. You don't have to memorize the numbers, that's not important. But primarily it's auditory in the temporal lobe there, okay? So not a whole lot that we localize in that temporal lobe. Let's go to occipital lobe for just a minute. Occipital lobe, back here, okay? Occipital lobe is PCA territory, so now we're getting into the posterior territory. So the primary visual center receives that input from the optic nerves, and then you have some special sort of cells in the thalamus to help us determine what we're seeing. So you have some vision association areas as well, but again, that primary PCA territory is going to be the vascular supply. So if you have a top of the basilar occlusion, you might have cortical blindness, okay? That's why you're checking the quadrants, you know, of these patients too. Okay, I would know this. I'm just gonna flat tell you. I would know this. The course of visual stimuli is I see it. The retinal ganglionic cells for the vision, bring that visual image through the optic nerve fibers to the chiasm, and then to the optic tract, and then to the lateral geniculate bodies, and then it finally gets back to Brodmann's area 17 of the occipital cortex. That's a long way to go for something. So anywhere along the way can create some disruption in your vision, okay? So anywhere along the way can create disruption in the vision. And, I keep trying to do my slides here. I don't know why that is first. Okay. 17 is the primary vision, and this is your vision association area. This helps you interpret what you're seeing, right? And 18. So you have all these areas, and then you have association areas that go along with them, which makes sense because it doesn't do me any good to see something and then not be able to associate it with something that I know. That doesn't make sense as a human being. You know, I have to make sense of my environment. So this is your visual cortex back here. Okay. This is your visual field localization rules right here. When you have a patient that has poor attention, or they have some sort of cognitive impairment that affect their corporation, you have to use confrontation, and you may have to use threat. How many of you have had to use threat? Yeah, I've had to use threat too. And you have to be sure when you're using threat that you're not creating air that causes them to blink, you know, or and so, but you have to confront them, and you have to use threat when you do it. The other thing that I would say is that when you're using, when you're doing your NIH, we'll talk about that in just a minute, making sure you're eye level with them if they are cooperative, because what happens is they're lower in the bed, I'm up higher, you know, my vision fields is not gonna be the same as theirs are. So you wanna make sure that if you are, especially when you're doing your NIH or checking vision fields, that you're on the same level with them so that you know if you can see it, they should be able to see it.
What's your technique for threat without causing air?
I go more lateral with them. I go lateral this way. I don't go straight on them.
Okay.
Because sometimes the air from,
right.
And I don't go way out here either. I go, you don't have to come way out here, because if you come way out here, if you do it to your own eye, you really create a lot of wind.
Mm-hmm.
You don't have to do that. You can just do very.
So my running start is probably not helping.
I mean, you should have, if you do this very like, you don't have to go way out here.
Mm-hmm.
And I see some people doing that like this, that stimulates a lot of wind.
Mm-hmm.
And so, and I don't think that you're gonna get what you need, you just need a little bit.
Okay.
Yeah. This is important, defects of one eye, this is the reason why you do eyes separately. Defects of one eye is known as monocular. That is the retina or optic nerve. If you have defects in both eyes, that is the chiasm or beyond, okay? If it's binocular, you probably will see that again, that distinction. And because of that, these people who have homonymous hemianopias, they have, like, here's their vision. The vision in both eyes is out on this side, right? So their medial vision on this eye is out, and their lateral vision is out on this side. That's always beyond the chiasm. That's how you can kind of localize that. When you have double vision, it's almost always caused by lesions affecting the brainstem, these cranial nerves. 3, 4, and 6 always work together. And so to keep the eyes together, remember that saccadic movement we talked about before? Allowing my eyes to move together. One doesn't move apart from the other, so I can see very clearly over here. I can see very clearly over here. If I have an eye that doesn't move well, I'm gonna have a disruption in my vision, maybe double vision. So double vision, if a patient comes in with double vision, and you really need to pay attention to their cranial nerves, okay? because they may have something in the brainstem, and I'm gonna tell you something. You might be the only person who knows that, and you may be the only person who pays attention to that piece. Cortical blindness is horrible. How many of you have seen a top of the basilar cortical blind patient? That's a really sad situation if it really causes a lot of stroke. But it may result from a single or even consecutive events where they're small and they're just cumulative. But again, it's most often the result of simultaneous or successive VCA occlusions and top of the basilar occlusions, whatever. The guy that was on the seat, that was on the table, was headed to this. He was headed to this, for sure. I mean, literally right in front of me. So that's just a devastating thing to have to happen. Okay. So we've talked about motor strip, we've talked about all kinds of other things. Let's talk, and we've talked about that gray matter in the cortex. So let's get below that and get to the cerebellum and the brainstem. Okay? The subcortex is filled with ascending sensory. Don't get confused on that. If I step on a nail, it's gonna come up my spine, so I can interpret all that, right? So it is ascending, and then descending motor fibers. The basal nuclei and the thalami, all of these things right here. And of course the thalami is the relay station of the brain for sensory, okay? This is why lesions affecting that subcortical region, anywhere down in here, you get pure sensory or pure motor or combined sensory motor. And that never made sense to me, but if you have someone who has pure sensory deficits and they don't have motor deficits, that's pretty clear that that's a subcortical stroke. If they have pure motor and they have zero sensory, then you go, okay, could this be a lacunar stroke, right? Because it's in the subcortex. I never worried about, I mean, you may be tested on this in terms of do you know that? For me, I was like, what does the MRI say? Because I can sit here and I can say all this right now, but I need the MRI. So, anyway, just know it's these pure deficits that can get you, because that MCA territory covers motor and sensory strips. So a lot of times you have them coexisting together.
And you're saying those are the lacunar?
Yeah, so if you have pure sensory, pure motor, and you can have combined sensory motor, right, with MCA, with large vessel occlusion too, right? You can have that, but if it's pure sensory, like they're totally numb on their left arm, but nothing else, then you kind of, okay, do I have a lacunar stroke? Do I have a small vessel or a subcortical stroke? Yeah. Let's talk about the cerebellum for just a minute. The cerebellum is smaller part of brain volume, about 10%. And of course, there's two lateral hemispheres to that, and it's connected by the vermis. Cerebellum, and you'll know this because of your NIH, right? Your cerebellar functions are fine motor, or fine coordination, maintenance of the muscle tone and posture, and there's two different types of movements. This is, there is appendicular ataxia and there's truncal ataxia. Truncal has to do with this muscle tone and posture. I can do like this and I won't fall over, right? Because my cerebellum's intact. If my cerebellum was not intact, I would have trouble sitting up or sort of standing up even with PT because I don't know where I am in space, right? Okay. The vestibular apparatus in the inner ear is continually delivering messages and stimuli to keep us in equilibrium. All right. So ipsilateral. What is ipsilateral?
Same side.
Same side. Yep. Yep. So ipsilateral dysfunction, you can see alterations in equilibrium, right? They're going to walk like this. They should be walking straight. They're not. And coordination and ataxia, inability to coordinate motor function. And we see that on our finger, nose, finger. Now the thing about the finger, nose, finger, and we'll talk about that in stroke scales, is you've got to have them extend their hand, right? If you do this with them, they're using these proximal muscles and you won't see the ataxia. that goes with them, so you've gotta get them to move that out, okay? Ataxia is nothing more than inability to coordinate that motor function. Cerebellar infarcts commonly occur in association with brainstem stroke. If you remember, the cerebellum, the vascular supply, goes up the basilar into the posterior cerebral arteries, and so if you have an infarct, or if you have embolic material going through there, it's going through the brainstem vessels, right? If you remember that, circle of Willis and the vertebral arteries and how they go into the basilar. And then you have presentation includes the findings of a cerebellar stroke. So you can have motor weakness, you can have sensory loss, alterations in consciousness and cranial nerve policies should let you know, just like the guy with the one, the arm drift would have made me think, okay, maybe I have an MCA situation. Maybe I have stenosis there. But the fact that his eyes, he had a cranial nerve problem, I was like, brainstem or posterior circulation. So once you start localizing this, because they might come in unconscious too. And once you identify a cranial nerve palsy, and that can happen whether or not they're awake or not. If they have an eye over here and another eye straight, they've got a cranial nerve palsy. Okay, so cerebellar localization primarily is in the balance. That's why we add the balance in the eyes, right? To that be fast. Okay. The brainstem has all of these motor control centers, level of consciousness, cardiac, respiratory, vasomotor. Can you maintain your blood pressure? My daughter, every time she gets scared, her eyes dilate and she faints. Well, she's vagaling. And so anyway, so now when she has to give blood, she knows that she has to lay down and they have to put her feet up, otherwise she's gonna pass out. Well, that's, it's not a hypovolemic problem, she actually vagals out on. Vomiting, even sneezing. Again, all of your pathways go through here, and that only makes sense because things have to get from your extremities up through your spinal column, up through the brainstem, and then digging out with the thalamus, and the reverse is true as well through that corticospinal tract. Your cranial nerves here, we talked about that, are housed in the brainstem. You've got a nice picture on that, and you can look back at that. You'll never have to forget where they are. Remember where they are again. You will always know where they are and what they do. I do want to say something about level of consciousness because we use these, we use obtunded. We really don't use coma when probably we should. But alert is wide awake. So that's important to know. So if you get a question that says, the patient had eyes closed and, what is their NIH? Well, they're not wide awake. They do have their eyes closed. You do have to arouse them. So they're not exactly wide awake when you walk in the room. Lethargic is sleepy or dull and indifferent. Obtunded is a deep sleep and you can hardly arouse them. Stupor, the difference between stupor and coma is stupor responds normally to noxious stimuli. I'm gonna pull away, right? I'm gonna pull away. I'm getting away from you if I have to do cap pressure. I'm pulling away. Coma is abnormal, and you can have decorticate, decerebrate, you can have a combination. I've seen combinations in some of these brainstem. So just know, I think obtunded most people know, but stupor and coma, the differentiation is how you respond to stimuli. Let's talk about midbrain a little bit. Let's finish up on the brainstem, okay? The midbrain extends from the pons to the thalamus. We drew that little, square just a moment ago. The thalamus sits on top of that, on top of the midbrain. Again, you have that visual reflex centers, your pupillary dilation. That's what that means for your head and your eye movement. Okay, so you have really. You have a couple of cranial nerves that are the pathway for pupillary constriction, and that's really your 3 and 4, mainly your 3. So if you have a midbrain stroke, you have dysfunction in your extraocular muscles. You also have pupillary dilation because of that unopposed sympathetic response. you have a decreased level of consciousness typically, and you have motor and sensory dysfunction because everything goes through there, everything. And so you have that dysfunction there. The other thing that I would say is there's a lot of, watch out for mid-position, what we call mid-position pupils, which again are, you can have everything sort of the same, but if you start noticing that pupils are 4s, and start noticing, do y'all use pupilometry?
ICU does.
Huh?
ICU does.
ICU does, yeah, yeah. So,
Well,
you
it kind of
know, so my neurosurgeon goes on the unit and they said, well, you know, the pupils are this and the NPI is 0. And he goes, well, how do you know what the pupils are? And she goes, well, I put the pupilometer on it. Because she told him that pupils were like 3.2 and 2.7 or something like that. And so he just didn't understand how that can happen. So anyway, so the pupilometry can really, especially in patients who are sedated, especially in patients who have smaller pupils, and some in the ICU, it's used mostly in the ICU setting. Okay. So again, that brainstem, getting that midbrain. Okay. Again, that pontine localization. And again, this particular slide set has cranial nerve 8. 8 kind of sits sort of in between. But it's the bulge in the brainstem right here. Pons right there. So you have what cranial nerves? 5, 6, and 7, and maybe a little bit of 8. But this is your apneustic center and your pneumotaxic center. So your apneustic center, does anybody know what that is?
promotes inspiration.
Yep, it promotes inspiration.
So,
Yep. Did you just read that?
Yeah, it's next to it in the book.
I was like, man, I thought it was gonna like tell you something you didn't know. Okay, yeah. The pneumotaxic center keeps you from being like overly inflated, right? There is a limit to what you can inhale. So the pneumotaxic center says, okay, the lungs are expanded enough. So it has to do with your respiratory center, right? So when we have pontine strokes, people can have weird respiratory patterns, right? And so you have EOM dysfunction because you have cranial nerve 6 sitting right here. You can have decreased LOC as well. Cranial nerve and motor sensory dysfunction, all bets are off. Anything can happen with a brainstem stroke. And I'm gonna tell you, I never tried to figure, I'm just gonna be honest with you, I was like, we have a brainstem problem, or we have a posterior circulation problem. I was more interested in sort of, I mean, you need to know how to pinpoint it, but I was more interested in how do you support the patient and how do you support their respiratory status and how do you prevent a complication like aspiration and all of that kind of stuff in these particular patients, because they can go pretty south on you. And that's really where this guy was with this. It scares me all the time. I hug him every time I see him in the hallway. I really, truly do. I said, I'm so glad you're still here. I'm glad you didn't, like, you know, throw a big clot when I was sitting there with you in the CT scanner. But again, obviously respiratory dysfunction. And let's look at the medulla for just a moment, okay? Let's look for the medulla. So this slide said it's gonna have you have 8 in here. That's okay. The pyramids of the medulla, these are the bulges of the white matter containing the fibers of the corticospinal tract. What the heck does that mean? This is where the crossover happens. This is where things cross over in the medullary pyramids, and this is why right is left, the left is right, right? That's why the left controls the right controls the left, is they cross over in these pyramids, these medullary pyramids. And so stuff comes down from the right side of the brain, but it crosses over, and now it goes to the left side. Okay? Again, cardiac, vasomotor, and respiratory centers here. And a medullary stroke, again, decreased LOC in all of these. So when you see a decreased LOC, and then you have a pupil going over here and a pupil straight, then you need to think, okay, maybe I have a brainstem stroke here, okay? Basal artery thrombosis, it's one of the most commonly misdiagnosed of all ischemic infarction presentations. The other common one is right-sided lesions, because patients will be neglectful on the left. and they won't know that there's a problem. But this is the most commonly misdiagnosed. Mainly because they're altered level of consciousness, and people are like, well, how come they have this altered level of consciousness? So, or how come they won't wake up? You have to think about this in a patient like that. Okay, they may include either the following: vertigo if they're awake enough to know that, motor sensory loss, obviously cranial nerve palsies, hiccups. People don't think about hiccups either, and shivering. Interesting presentation right through here. The most severe symptoms include tetraparesis. Tetraparesis is weakness in all the muscles, including respiratory. So these patients would be ventilatory dependent, and they'll get respiratory failure. Altered level of consciousness. Locked-in syndrome is horrible. How many of you have seen locked-in syndrome? It's horrible. I mean, I had a patient that came in and had, of course, all you can move your eyes, and that's all you can move. You can hear everything. You can't respond to anything. I mean, to me, it's the most miserable of all stroke syndromes because of that. And his wife opted because he was totally tetraplegic.
There's a really cool book called The Butterfly and the Diving Bell.
Uh-huh.
Have you ever heard about it?
Mm-mm.
The person that had locked-in syndrome, the family hired a somebody to write a book.
Yeah.
And they did it as like, looking this way, that way, whatever, and they ended up, it's a short read, and it's their perspective of being in the locked-in.
Oh, wow. Yeah, because they're aware.
There's like an implanted laser that you can implant in the patient, and they can communicate through a computer.
Yeah, excellent.
What's the
Yeah.
book called?
The Butterfly and the Diving Bell.
Nice. Yeah, this is, to me, because they're aware, they can hear everything, and they're totally aware. I mean, to me, that'd be the most frightening of stroke symptoms. It's one thing to have a stroke and just not be aware of it. It's a whole nother thing to have a stroke and have people talking about, when you know that you're there, cortical blindness, again, because of those bilateral PCA occlusions from the top of the basilar syndrome. So again, okay, here's our localization rules, and this is what will be, I don't know if that's in your book, I hope it's in your book. Yeah. Now here, this is what's interesting. Okay, loss of sensory and or motor loss that's on the same side involving face and extremities indicates illusion anywhere. Okay? So if you have loss of sensory and or motor loss that's all on the same side that involves the face and extremities, you can have illusion anywhere, okay? The coronal brainstem stroke findings are bilaterally, so you have them, and you can have mixed signs. So you can have cranial nerve deficits on the same side as the impart, but you have opposite side extremity weakness. So if you have mixed signs like that, think brainstem. Other things can be brainstem lesion too. They're kind of off the wall, like one-offs, like auditory, like hearing loss, vertigo, double vision, or any other cranial nerve finding. Sudden loss of consciousness in a non-hemorrhagic stroke, think brainstem. So you need a non-con CT, you need a CTA to look at those vessels, okay?
So with your guy that you evaluated, he had left side drift, but then you coupled that with the cranial nerve deficit, so then you think that's cerebellar related, or?
Yeah, as soon as I saw that, I was like, I don't need to localize anymore.
Right.
I don't need to fine tune the localization. I know that we have a brainstem problem right now. And so, yeah, I knew immediately. And so I was like, I don't have to put any more thought into this. I need imaging now. The main thing about all of this is not that you pinpoint the things. Now on the test, you might have to know these things. The main thing is that you think about it when you see this mixed stuff happening, that you bring it to somebody's attention, because I can tell you sometimes it's not on their radar. Like if you have a rapid response, you have a rapid response here? Mm-hmm. Yeah. So if you have a rapid response and you have these mixed signals that nobody knows what to do with, and it involves cranial nerves, then maybe we do need to think about that, because you may be the only person in the room that says, hey, we need to work this patient up for stroke. I know it doesn't make any sense, doesn't localize, but brainstem strokes are not always straightforward, for sure. But yeah, but as soon as I saw that, I didn't need to do any more thinking. I was like, on to imaging.
That's your focal deficit right there. Yep, okay.
Yeah, and then moving on, I don't need to tell, I just walked out there and I said, I have 1.5 syndrome in a left arm drift. This is what I'm doing, I've already initiated it, I've already given the order, and they're already doing it. And so, and the poor neurologist, she goes, oh my God. I said, yeah, I'm glad I came down here because I was gonna just not commit. So anyway, but yeah, but those are the patients that stay with you, or those patients that teach you a little bit something that you didn't know, you know? Those are the patients that stay with us. Okay. So that is localization. So, okay, are y'all doing okay right now? Moving on to stroke scales. And I think that this is gonna be very, very brief because you already know stroke scales. Okay, there we go. Okay. One of the things that, why do we need a stroke scale to begin with? You know, these things weren't just dreamt up because nobody had anything else to do. When we were doing the early trials in the throughout the 80s and even into the 90s to try to figure out what we could do to help stroke patients. I've been around long enough to be around when nobody wanted to give formulaics. I didn't believe in them. And I worked with 2 physicians who wouldn't give the 3 to 4.5 hour. They wouldn't give anything in that window. And so that was hard as a clinician, knowing why we needed to do it, and then I had people who didn't do it. So that's hard when you work in an environment sometimes like that. But we needed the stroke scale to be able to have a valid way of looking at disability in patients who are gonna be enrolled in these trials, so that we get a validated way to look at them before and after. And without those tools, you had no validated way to do it. So the NIH stroke scale was developed for that reason, to be able to assess patients before thrombolytics and then after thrombolytics, and be able to have a valid measure. That's why it was created. It has validity and reliability in ischemic and now hemorrhagic stroke. The other thing that I would say in hemorrhagic stroke is if we will code the NIH, and Kirk, this may be something for you guys to know about, if we'll code that NIH score, that CMS recognizes that, you know what, if they come in with an NIH of 25, they're coming in very severely at risk for disability. And they're gonna be at a higher risk for mortality. And so CMS is recognizing that there's only so much we can do when you have a patient with that kind of severity. And so they're starting to recognize that. Score ranges from 0 to 42. We know that in a perfect world, they're not gonna get to 42, but there's a severity bias. And I would know that, I think this is not news to you guys, for left hemispheric stroke, because there's 7 points related to language, only 2 points related to neglect. And where you get the neglect from is right-sided deficits, not left, okay? So the points related to language refer to the left side of the brain. The points related to neglect relate to the right side of the brain. So there's a disconnect. So that puts a bias for left hemispheric strokes. And also there is a severity bias in terms of differences in the median infarction volume. I wouldn't worry about that too much. I will worry about this right here, is that there is a bias related to that, okay? What I would say on this, what I have been told, and I will openly share, is that someone told me that there were, that they needed to be familiar with the scoring on this. So I would review the NIH and know that if you had a patient who was in a stupor or a coma, knowing how to score that patient, okay? I have never done an NIH or scored an NIH where I didn't have a way to look at what the scoring system was, because, again, I think memorization in a really urgent situation leads to mistakes. So I never did it. I had my NIH cord out there every single time I did it, and there's no shame in that. Because you want it to be accurate. So again, one of your items, one, or degree of wakefulness, I talked about, are they awake? If they are laying there with their eyes closed, I think the assumption is they're not, if they have their eyes open and that, they're awake. But if I sat down and had my eyes closed, or even if you close your eyes, I'm gonna think you're not really awake, okay? So making sure and score that correctly. And then the commands. So just make sure you know the scoring on this if you sit your NVRN. The NIH tests lateral movement only. There's none of this H. It's lateral. Can you move it here? Can you move it there? Right, because you're gonna get most of your cranial nerves that way, in terms of the eyes. So that's your best gaze. And that allows you to know whether or not you have an abnormal gaze. So you may have a preference, but you can overcome it a little bit, but then it goes right back, or a total gaze, okay? The doll's eyes, you can use that if necessary. Again, the force deviation is gonna score 2. And so you can use that, and that's where you hold their head, and I'm assuming that they don't have a spinal cord injury, but you hold their head here, and if you move it, and they go like this, that's abnormal, you shouldn't do that, okay? And it's taken from the dolls, and, when they had movable eyes, and these ceramic dolls, the eyes would move, so if you move their head, they would move like this. Right, and they would stay front.
Looking at you?
They don't do that, huh?
Were you saying like looking at you?
Yeah, so when I do doll's eyes, and I move somebody's head really abruptly, their eyes should stay like this if they're intact. The problem is when I have to do a maneuver like that, they're almost never intact. You know, there's a reason why I have to do that maneuver. And so, but if those cranial nerves are intact, then they'll move like this. They'll still stay front. Yeah.
And so, on the abnormal gaze without force deviation, you were saying like when they do have a weird gaze, that you can sort of get them to come
Yeah.
out of it
Mhm.
temporarily.
Mhm.
So it's not,
Yeah.
okay.
Yeah, because some people will have a total gaze deviation where it's not just a gaze preference. They'll have a gaze deviation where they cannot overcome. Like they cannot move their eyes. Look over here at me, and they're going, I'm trying. And that's what Scott was telling me. He was like, I'm trying. I said, did you hear me? Follow my finger. I mean, I actually said that to him. I said, did you hear me? Follow my finger. He goes, I'm trying to follow your finger. And so, anyway, but if you have one over here and they can sort of get over here, but then they go back here, that's more of a preference.
Gotcha.
Yeah. No, you're good. We're not gonna watch videos today, okay? Not gonna do it. The vision field, again, like I was telling you, use your stuff for confirmation. So if I'm doing it, sometimes I'm stooping down and going, hey, do y'all do, how many fingers do you see? Do you do that? Okay. Sometimes it's hard for people to see how many fingers you have. And sometimes it's easier to move. And where do you see my finger moving? I always want them to point. You know, I always say, point to where you see my finger moving. Because then that way, or my hand moving. So then that way they can, that way they don't have to worry about saying 1 or 2 or whatever. They can just point to where, because I don't care about 1 or 2. I care, do you see me? And test all 4 quadrants using single and double simultaneous. So one eye, and then do they extinct in both eyes, okay? So the results from this can be used to score extinction. So if I have them here, and I'm like, where do you see me? And they can't see that, or, and I do this, and they go, hey, I see that one, but I don't see that one. You know, then you can use that to score your extinction too. So trying to sort of combine your assessment. Quadranopia is a quadrant that's out, scores a 1. Complete hemianopia is a 2, and then bilateral loss is a 3. And use the threat if you need to here. We're not watching a video. This one is real easy to me. And so many times when you're seeing these patients, you'll notice very quickly whether, if I go in and I see a stroke patient that has arm weakness
and they don't have it obvious, then have them smile, and then you can see that mild flattening. But most of the time, you're gonna be able to see this pretty clearly when you're as you're talking to them. The arms are tested for 10 seconds, legs tested for 5. And so the scoring depends on whether or not it drifts, hits the bed, or they can't move at all. So the score is different, for them, okay? So it's 10 seconds, legs for 5 seconds. And honestly, for a whole leg, that's pretty, and some of these elderly people, that's pretty challenging for them, especially if they have like hip issues or they have a lot of arthritis. Sometimes that can be really difficult for them.
I have a question.
Uh-huh.
For the motor testing, if they are weak already, baseline, usually.
Oh, it's hard, isn't it? Yeah. So if
I've
they're
heard
weak,
contradicting things.
yeah. If they're weak, I think you score what you see, because you don't know. This is the first time you're seeing the patient. Score what you see, and then you can always put a note in there, they had previous stroke, they had right hand here, but score what you see. I don't think that there's any, I think what is challenging is when we don't score, or we try to score new deficits, and the reality is, especially when we first get these patients, we don't know what new deficits are, and just always score what we see. Yeah. Yeah, but it is not a solid answer on what to do. I think as an institution, the institution needs to figure out, okay, we're gonna score what we see, because we don't know. And honestly, they can have weakness before, but now they're plegic. You know what I mean? And that's where I get to where that definitely, they had weakness that weakness means all kinds of things to all kinds of people. So it's better just to score what you see, and then you can put in there that the family said that they had weakness on that side, and then correlate everything together, when you look at everything in totality. Yeah, but that's a challenging one, for sure.
That's what,
Yes.
You go first.
NIH, like, I just redid my NIH certification, it says even if it's like, what you just score what you see, even if you know, like it was a previous stroke or
Yeah.
some other kind of.
I think it's the safest thing to do, so I'm glad that they've incorporated that, because depending on who you get to redo your thing, they've sort of vacillated on, and there's been a lot of conversation too about it.
Yeah, I
too.
think over the past 10 years, I guess, since I've been there, I feel like they initially said, don't
Score the new
them
stuff, yes.
if
Uh-huh.
they have recorded, if they're already weak or like something else, you don't score them. But then recently,
Yeah, I think that's the safest thing, is just to do what you see, and then let us sort everything out later,
Just going back to the facial policy real quick.
Yeah.
So if I remember right, you were saying that the lower face, like if it's just the lower face, we suspect that there's NCA, upper face is involved, you suspect that there's brainstem involvement.
Or Bell's palsy.
Or Bell's palsy. If we're seeing both and we have a confirmed deficit, is it like almost always brainstem when you're seeing upper and lower, or is it like some NCA involvement as well?
Well, I think, so it could be, honestly, if you have big strokes, it could be, very rarely combo.
Yeah.
But most of the time, it's gonna be lower face. Your upper face is not gonna be affected by your NCA.
Okay.
Typically. But I can tell you with brainstem, all bets are off.
Yeah.
And you should see some other things, not just that.
Yeah.
You should see some other stuff with it. Yeah, and that's the reason why even the patients that come in with Bell's palsy and that kind of stuff, the neurologist was like going, I don't see anything else, and I was like, well, this is like typical Bell's palsy. They would always get an MRI. Now, whether or not that's good practice or not, I don't know. I think it was a little overkill, but they did it just to be sure that there wasn't anything going on.
But like you said, like brainstem is like you get all the.
Oh, look, you get
abnormal
mixed stuff, you get stuff that doesn't make any sense. And, and even for me, it doesn't make any sense sometimes. And so, but what helps is if you know that you have a patient like that, then to go back and look at their symptoms, and then that makes it real. That kind of cements that. Yes, ma'am?
We have a patient, not too recent, or not too long ago, and the upper part of their face was affected, but not their lower part of their face, and it confused the crap out of everybody on how to score that. Or if it was actually something but it was new since their
That
stroke.
is weird.
Where they were able to smile when you asked them to raise their eyebrows.
They couldn't.
I mean, it was like they had Botox their entire top of their face.
And they had not had Botox.
No. No, but I mean, they
That's
couldn't
very
raise their
interesting.
eyebrow, and
Uh-huh.
it was just like,
So what did they decide it was? That would be so atypical. I wouldn't even know how to vocalize
well,
that.
nobody knew how to score it. That was what we were, that was like a thing, and of course,
Uh-huh.
I went off shift and I was off for 4 days, and when I came back,
See,
they were gone,
well, it
so
wouldn't be
I-
scored, would it? It would be, I mean, if you just had that, if you didn't have the nasolabial fold,
Right,
it would be at 0.
They didn't have nice little report, they just had the upper.
it was just the upper.
That's so
It
weird.
was just like, this upper part of their face, they couldn't move, like, they could move this part, no problem, and it was just like somebody had just Botoxed the crap out of this, where it was, even their eye was a little droopy.
So there's some, so I wonder, I
But it
still
was
wonder,
new.
yeah, I still wonder if that's a little bit of a Bell's.
That's, yeah,
You know what I mean? A little bit of a Bell's palsy. It may not have gotten the whole nerve yet,
yeah.
because there's some redundancy. So I wonder if it's still like a early, or an atypical presentation.
Yeah, cause we were
That's
just putting
interesting.
notes on there, just being like, top part of the face, not moving,
Yeah.
don't
on
know
the
what
right
to tell
side.
ya.
Yeah.
Yeah,
I wonder if it's an atypical Bell's. That would be so rare.
it was so weird,
See, those are the things that I wish you could follow up on. You know what I mean?
yeah.
Yeah, that's a good one. That's really weird. I just wonder if I wonder if it's an atypical Bell's presentation.
Yeah, that's
Which would be totally weird.
But that's kind of wondering if maybe it had triggered like a Bell's palsy, like it was coming on slowly, and, or
Mhm.
like if in the coming months, if maybe it would turn into a
A full blown thing.
Bell's
Yeah.
palsy or something, but it's like,
Well, hopefully they treated it like that
yeah,
to prevent anything else, because nothing is worse than having I mean, I can deal with the upper face,
Mhm.
not being able to, you know, like raise my eyebrows and stuff like that.
Right,
But it's really hard when you can only make one side of your face.
yeah, it was bizarre.
That is, no, I agree with you, I've never seen that, but that is bizarre, yeah. Ataxia is the most commonly misscored item in the NIH. It's always absent until it's present. So, if weakness is a factor and they can't move that arm, don't score them with ataxia, they can't do their fingernails finger or anything like that. So this is the most, it's only scored present if it's actually present, okay? So this is one of those that, people will confuse that, and patients will be weak, and then they'll go, well, they're like this, I was like, no, that's because that's the side that they're weak on, okay?
So if they have hemiparesis, we're expecting that side to be
I
flaccid,
score that 0,
so that's a 0,
it's not present in that side.
right? And if they have like a limited mobility problem with their shoulder, cause of like a rotator cuff, so they can't go like this, that's already present, so that's a,
How did they
that's
tell you
a
how to
0.
score that when you took your recent NIH?
They say don't score if it's not present.
Yeah.
Like they put some detail, it's the same exact videos from
Yeah,
50
yeah.
years ago.
Yeah, you only score it if it's present, if it's not present, it's 0.
They had like an amputated limb option, like the last.
They did,
Oh, I
they
get
did.
it,
But you see
limb
that,
not
don't you,
present or
there's
something
Limb not
like that.
present.
We'll
Yeah.
score it like a 2,
Yeah.
because they
Yeah.
can't move
Updated the
this part, and it's like,
cards.
that's
No, you
not
can't
limited.
Oh, they
score it.
did, very good.
Yeah, we can't score it.
Oh,
Sensory,
amazing.
now, I had my patient close eyes. Because I think that makes the most sense, if I'm testing their sensory, I have them close their eyes. And again, start with that unaffected side. And you can combine your double simultaneous for extinction and collect with this. You know, because you're trying to go fast with it, to be honest. And one of the things when they teach you with the they go in this order. Well, they did that because the original trials had you go in a specific order so that everything would be the same in protocol. So you wouldn't have to say, well, they scored this, or they did this before that. You wouldn't have any of that. So when they say do these in the exact same order, that was for the research study that we're being done. We're in time crunch, and we have to know the NIH before we do anything else. So, you know, combine those things. They probably told you not to do that on that. Yeah, they told you not to do that.
Not to do that, but
Yeah.
I do.
I do too, and, it makes the most sense to do it here. Where am I touching you? Where am I touching you? Where am I touching you? right?
Especially when a lot of times cognitively they can't handle that.
That's right.
Many questions.
Yeah, no, 100%, yeah,
You're
'cause
playing
they're
with their
getting a lot.
legs anyway,
Huh?
so if you're playing with their legs anyway,
You're doing it anyway,
doing this,
that's right.
like, might as well stay there.
That's exactly right. So language, what have you got on you? You know, I didn't carry that picture around with me. What is this? You know, what is my, what is a pen? What is a, you know, I turn on the phone, what is this? It's a flashlight, okay. And so, again, the reading phrases and that kind of stuff, we do that in the more of, subacute, but you can actually know pretty quickly the stuff that's on you. I guarantee the mobile stroke unit, they don't carry around that. Can you say mama? Can you say tip-top? Can you, you have to do it, you know, to complete that. But in the heat of the moment, when you're trying to get an NIH score, I think some of those things are sort of, deferred just a little bit. But again, reading those phrases out loud also tells you a little bit about their vision too. Okay? All right.
Score them a 3 if they're intubated.
Huh?
Score them a 3 if they're intubated.
Yeah, the score 3, that's right, we have those intubation things, if they're intubated, or have, sort of an altered level of consciousness, what do we score them?
But on 9, you score them 3, and then on 10, it's untestable.
Yeah.
It's so weird.
I know,
It's great.
you give them the worst that they can do, but they're intubated,
Yeah.
and sedated, and all the things, yeah,
Except for they get
exactly,
excluded the next question, doesn't it?
yeah. So dysarthria, by this time you should know whether they have dysarthria. You don't know by this time they have dysarthria, we have a different problem. So by this time you know that they have some dysarthria here, okay? And then neglect, again, again, profound is in more than one sensory modality, so, arm or leg, okay, special tube, okay? We're not gonna watch this video. This video is literally from the 1980s. We're not watching. One of the things too is that sometimes we use these slim, NIH exams and the Glasgow Coma Scale, and we use that GCS all the time. It's validated in trauma, but it goes in all of ours, particularly our ICU paperwork, and all of that. And so, Anne had a student that actually looked at some of these slim versions that were tested against the full, NIH. And honestly, these slim versions are not tied to the vascular territory, because that really is what you're trying to, assess in terms of deficit. And so they're invalid in terms of, detecting deficits. And again, that GCS has no relationship whatsoever to disability. Okay, last one, modified Rankin. This is what I want you to know about modified Rankin. Do y'all get that on a discharge? Do y'all get a modified Rankin on discharge? Yeah, we do too. And then again, in, 90 days, you have to have a 90-day modified. And it ranges from 0 to 6, okay? What you're gonna see in the reperfusion therapies is this, and the reason why I bring this up is this. The NINDS, RTPA trials had a good outcome, so you have to know what good outcomes are. Good outcomes from the NINDS RTPA trials in 1995 that resulted in the FDA indication for acute ischemic stroke for alteplase, 0 to 1. Okay, pretty stringent criteria for outcome. Okay, so 0 to 1 here. No significant disability with one despite symptoms, but they're able to carry out all their usual. So the patient that was on the table that now works with us has a modified Rankin 1. He still has some, but he's able to work and all that kind of stuff. The thrombectomy trials in 2015, a good outcome was defined as 2 or less, okay? So a good outcome is a slight disability. They can't do everything they used to do, but they can look after their own affairs without assistance. So maybe they can, maybe they can't drive, but maybe they can dress themselves or that kind of thing. Or maybe they walk with, maybe they don't need any assistance walking and that kind of stuff. So 2, and there's questions that sort of, lean toward getting you to one of these numbers. 3 is a moderate disability, They require some help, but they're able to walk without assistance, okay? So they require help dressing, that kind of stuff, but they don't need a walker, they don't need any of that. A lot of your ICH trials are 3 or less, okay? So we're increasing the amount of people that we're saying have a good outcome, but the criteria is different. So if we said that 2 or less, and what that is designed to do is have more people have a good outcome, so this is an intervention that we should do. Does that make sense? Yeah? Okay. The switch trial and the ICH trial that said, we should do hemocraniectomies on a lot more people, they used a 4 or less was quote unquote good outcome. Some of the ICH trials that we're gonna see tomorrow, they dichotomize them, 3 or less is good, 4 or more is bad. So when they talk about, hey, this, a significant amount of patients had a good outcome, you need to know what a good outcome definition was in that trial, or in that study, or in that recommendation. Many people, you know, a 4 or a 5 is pretty severe disability for some people, I mean, obviously by definition, and 6 is dead, okay? So the modified ranking, when we do these trials, when we do these recommendations, and we're defining good outcome versus bad outcome, they're using typically either this or a combination or a composite score of this plus like a Barthel or Glasgow outcome score, that kind of stuff. So I just want you to know that because we're gonna see some of this tomorrow.
Why did they make a designation for dead?
Huh? Because when you do a 90-day modified ranking and you did an intervention, or
You
you
need
gave
to
a
measure progression.
you
Yeah,
need to know,
okay.
hey, where are they at 90 days? Because if the majority of them are dead, it's not an effective intervention. Mm-hmm. Yep. Okay, all right. I think that piece is, okay, you ready to go to neuroimaging? And then we're gonna finish up for today. Neuroimaging, there is a light at the end of this tunnel. There is a light at the end of this tunnel. This is often the